Hello and welcome, members of the Chinese Medicine Practitioner Meetup Group, hosted by Kamwo. My name is Thomas Leong. I'm the organizer of this group and your host for this afternoon or this evening's event, depending on where you are, where you're joining us from. So I want to take a moment to welcome all the new members to our group. I hope you will enjoy what we have lined up tonight, and hopefully this is the first of many events to come. The mission of our meetup group is to connect members with respected authorities on the subject matters within our profession and to create a space where members of our community can come together to learn from each other. The events are always free and our speaker suggestions come from you, the members. So if you have suggestions for speakers, send them to us. Currently, this is our 138th event, so that's a good number of events. By attending tonight, each of you will receive a $20 coupon via email. So please look for the email that will be coming in the next couple of days. And if you don't see it, look in your spam box. Your filter box or junk box, right? I think it's called junk folder. All right. Please mute your microphone, but feel free, and I would even encourage you to leave your camera on. Past meetup surveys indicate that it's a moral boost to see other faces when our community is sharing the same space. Gives us the cue to do so, to ask questions. And of course, there will be a Q&A session toward the end. If it is something urgent and relevant, please type your comments in the chat box and raise your hand. And I, as your host, will address it. This way, the lecture doesn't get interrupted. This talk will be approximately an hour to hour and a half long, and will approximately end at 8 o'clock. So if you got somewhere to be, 8 o'clock is when you're free. And now, without further ado, let me introduce tonight's speaker, Claudia Citkovitz. Claudia has trained some 270 acupuncture students and practitioners in the care of inpatients at the NYU Langone Hospital in Brooklyn. During birth in the US, and was her 2015 PhD study on acupuncture for stroke rehabilitation, 2015. Acupuncture during birth was published in 2019. Claudia is an active practitioner, educator, and peer reviewer, serving on the board of Society of Acupuncture Research and the Accreditation Commission for Acupuncture and Herbal Medicine, and as an associate editor of the Journal of Integrative and Complementary Medicine. You have quite a resume there, I have to say. Anyway, on behalf of our group, we want to welcome you, Claudia, and thank you for sharing your time with us. And if we all can give her applause, I think online we do this, right? Oh, did I lose my camera? I think I did lose my camera for a second. Okay, here I am. Did I lose it?
There you go.
You can.
All righty, Tom.
Welcome.
So good to see you all, and huge thank you, Tom. Enormous appreciation. I can say this. Back when I was still in acupuncture school and apprenticing for Tom Bizio and Frank Butler and Marianne Trevlione, I would always do the walk down from their offices over to Kamwo, which was smaller than that it is now. And, Tom would be there, and I'm not going to say exactly how many years it is ago, but a good long time, let's just say. So I've been so grateful to you and your whole family, Tom, just for everything you do for the practice. It's been a remarkable partnership that I feel just so grateful for. So thank you. And just to be able to do this kind of virtual online is just one of the great pleasures of life. It's like, I guess I must have done something right all of those days, getting up early to schlep to the hospital to, teach. I did years of PCOM shifts. I think I see some of you here who might have been on those. I did, just people coming for continuing ed, people coming as part of their DAOM program. And we did it in birth, but we also did it in stroke. And, so we treated, thousands of stroke patients over the 17 years we were there. And so I did my PhD and I walked away feeling like I knew a lot about how to deal with the effects of stroke on a person. I'll say a little bit more about what my PhD thesis was and all of that. But I wrote this title a long time ago, and I decided that there was a better title. I should have said why we really need to up our game right now on stroke rehabilitation and also on stroke preventive care. And it's really, really important. And why is that? Well, it's because stroke is increasing among young people. Overall, fewer people are having strokes and fewer people are dying from them because stuff is working, right? We all have our gripes about Lipitor and metformin and all of that. But in the old people who used to be getting strokes, they're getting fewer, but young people are getting more. And so I'll talk about kind of what the stroke risk factors are and how we can tease those out. There's the well-known Western risk factors, and then we can think about like the Chinese medicine risk factors for stroke, right? Like we can see that Da Huang, apple-shaped red cheek type and go, oh my goodness, phlegm, heat, stroke waiting to happen. So how we can be of help both in helping prevent strokes and also helping to clean up after when one does happen. That was already a problem, and it's going to be even more of an issue, I promise you, because a number of young people had strokes with COVID, and some COVID sufferers are also at increased risk for stroke. So that's the kind of why now. That I'm really turning back and doubling down on my stroke teaching and, bringing out my stroke research. I'm talking at whatever it's called, AAMA, Association of Medical Acupuncturists. Next year, I'm doing a mentorship and training program online. I'm really just trying to put the word out. So I'll give you a few quick tips on the acupuncture I do for stroke recovery and rehabilitation. Of course, I could give, that could be a whole weekend. It could be a 6-month training course that I'm going to do. But a few quick tips will get you pretty far. And then my favorite new thing that I learned during Zoom, during the pandemic, is that Zoom is a thing, right? That you can give a really nice consultation with somebody. So I don't know about you guys, but I eliminated the concept of the new patient visit after COVID. Why would I waste like our precious shared airtime sitting across from somebody? Instead, what I do is I do all of that like face-to-face with no masks. And then when they come in, kind of mostly I put them face down on the table, right? So their cooties are going straight down. And mine are going across, so that even, mask, no mask, whatever, I'm trying to reduce the cooties.
So with the hybrid,
Whoops, somebody needs to mute.
That's just all cloth seats. The LX is the base model.
Are we good? Okay, we're good. Anyway, so that's kind of all of what I want to touch on tonight. Obviously, it's a lot, but I think I can do at least a little bit of touching on everything. And we will have time to discuss. I mean, as Tom points out, a big point of these evenings is to have a chance to talk with each other, not just for me to talk at you. So look at that graph. Holy smokes, right? So the one on the left is deaths. And one on the right is disability adjusted life years. So stroke is what we call a growth industry at the moment. the older, as I said, the older people are having fewer strokes, but the younger people are explosively having more strokes, right? 46% over 13 years. That's an insane rise. And it's not a rise in all strokes, it's a rise in ischemic strokes, right? And so if we remember, ischemic is like a clog in the plumbing pipe, and hemorrhagic is like the pipe bursts and there's blood everywhere. So hemorrhagic are the more deadly ones, but ischemic are more common. It's like 80%, 87% of strokes are ischemic. Women's increase is bigger than men's increase. And that's weird because usually men have more strokes at the same age. Like at the same age as me, a man is going to have more strokes. Women have more strokes overall, just because women get older. But for the same age, men get more strokes. So the fact that it's increasing in women, that makes us think, is it the estrogens in the saran wrap? What is it? And then although the rise is in young people, the rise it's the older young people that are mostly affected, right? 35 to 45 is the worst getting worse. 25 to 35 is also getting worse, but not as bad. So as of 2019 and 2020, i.e. before the pandemic happened, the reasons they were talking about for this big increase were the usual suspects, right? Obesity, atherosclerosis, diabetes, illicit drug use is important, right? In particular, like weird synthetic drugs. Like there was this weird case of two brothers who both smoked some like synthetic off-brand weed and then both had strokes. So it's really clear that, feed your head, good stuff, not bad stuff. Also people who took the pill and smoked, oral contraceptives, people who have migraines with auras, those are women very often, are at an elevated risk for stroke, and that's going up. And then autoimmune disease is going up, and autoimmune disease is a stroke risk. So those are some of the reasons we think there might be more risks in women. And then, but of course, the usual suspects are not exercising, high blood pressure, binge drinking is a good recipe for a stroke, and then smoking. Oh my God, if you were like the evil Chinese medicine doctor and you wanted to give someone a stroke, you would invent cigarettes. It does everything that makes a stroke more likely. So literally 60% of your risk is just, low physical activity, right? And we know in our business, there's like that Bermuda Triangle of I'm tired, I don't exercise, and I have pain, right? That it's like stagnation, chi deficiency, stagnation, and more chi deficiency. So that is the youth risk. This I really want to share with you because this is a very well documented usual suspects of what causes stroke. And so typically what happens is either someone has a transient ischemic attack, which is like a mini stroke trying to happen, or they have a for real stroke, but they got the clot busters, so their symptoms aren't so bad, or they just got a diabetes diagnosis or something and their doctor read them the riot act and now they're worried. And so they have this like teachable moment where you could sit down with them and say, let's go through your risk factors and see what we can change, right? So that's, we've been helping people stop smoking since I was in school. And it's still a good thing to be able to do, helping people use fewer drugs, use less heavy drugs, use acupuncture instead of drugs, helping people drink, all of these things we can help people with. So we can help people with blood pressure. I'm not going to go deeply into how these statistics work. Basically, as a rule of thumb, you can think of it as a ratio, that somebody who has hypertension is about 2.5 times more likely to have a stroke than someone who doesn't have hypertension, right? And then someone who has heart disease is also 2.5 times more likely. So then you multiply 2.5 by 2.5, and you're getting it's not quite how it works. But the likelihoods compound each other. So smoking is a big one, that abdominal obesity, right? Apple-shaped fat, or what we'd call like a yang ming, da huang kind of a look. Diet risk score. In other words, how much Kentucky Fried Chicken and McDonald's do you eat? And how few vegetables do you eat? Regular physical activity, right? So somebody who does regular physical activity has only 70% of the chance of having a stroke that someone who doesn't. Heavy alcohol use. So either if you drink a lot or if you binge drink. I remember it was July, and I was recruiting for my PhD study, and I was freaking out because there were no stroke patients in the hospital, so I couldn't recruit anybody. And one of the physical therapists was like, "Oh, honey, don't worry. This isn't stroke season, right? Just wait. Thanksgiving and then Super Bowl Sunday, they'll be packed in here." And sure enough, right? Because what happens? They eat a bunch of fat, then they drink too much, and then they get angry about sports ball. And so then they all blow their gaskets and have strokes. And sure enough, winter is ischemic stroke season. And then actually February, people start having more hemorrhagic strokes, right? Because the yang is rising. So diabetes is a stroke risk factor. Stress is, depression also is, and then your cholesterol ratio. It's worth noting that there are a couple of things that cut differently for hemorrhagic stroke than ischemic stroke. Asian patients, both people from East Asia and also Southeast Asia in their heritage, the vasculature is a little different in the brain. The arteries are a little smaller, a little twistier. And so therefore the risk of hemorrhagic stroke is a little higher relative to Europeans and Americans, for what it's worth. It's like an interesting fun fact that you learn if you work at a hospital in Chinatown. So therefore, if somebody's at risk for hemorrhagic stroke, then they actually, someone who's, what's the right way to say this? A drink a day for men and half a drink a day for women reduces risk of ischemic stroke. However, it slightly increases risk of hemorrhagic stroke. So if you happen to know you're at risk for hemorrhagic stroke, you wouldn't do that red wine thing. So all of those numbers come from this study, which it was a phenomenal study. It was huge. They followed a bunch of people in a bunch, 22 countries. It's a really robust data set that we're not likely to get again for a while, because scientific funding is not that great these days, but it's from 2010, right? And that's a while ago, and people's diets have changed and people have gotten more and more obese, and whatever is going on with all the, autoimmune and autism and all this, something is happening environmentally that 2010 didn't know about yet. So there's a little bit of a grain of salt, except that we're not going to get better data anytime soon. And so then here comes COVID added to all of that. So with COVID acutely, I say Delta, but I actually mean everything up to Delta. So people who got the first round of COVID, a lot of those people were having strokes while they were sick with COVID. People would come to the hospital with a stroke and be found out to have COVID. And of course, it was the same thing that was destroying people's lungs. It was that runaway inflammation thing, because runaway inflammation in the brain makes a clot and makes a stroke. Omicron is definitely less of a problem than that, right? Like it's virus's job. As they evolve, they get less deadly, but more contagious. And so that's Omicron. So we think Omicron is not a problem. Hopefully there won't be some new variant that becomes a stroke risk again. But so people who had the early strains may be at an increased stroke risk. The post-infection stroke risk is less well understood, but probably those same patients who have long COVID, they have like elevated inflammatory markers, they have hypercoagulability, stuff like that. Those people are probably at increased risk after having had COVID. Now, if you look at the big picture statistics, Johnson & Johnson did have a stroke risk for, women under 50, and that's why they kind of stopped giving that in that population. But we're not going to see it affecting the population in big ways because not very many people got it. Now, Pfizer and Moderna, if they were causing strokes at the same rate, we would have seen them because so many people got Pfizer and Moderna. That said, when I posted the graphic for this talk, someone I know from my, meditation world in Madison, Wisconsin was like, yo, I had a stroke after I got my vaccine. Now, things happen after you do things, right? I mean, those of us who treat pregnant patients are always concerned that, we don't want to be the person who needled spleen 6 the day before somebody happened to have a miscarriage that they were going to have anyway. So this is why single cases don't prove statistical truths. But, these are the kind of conversations that we're trying not to have at Thanksgiving. If you look at the big picture statistics, they don't appear to paint a picture of Pfizer and Moderna causing strokes, but people who had the early strains are more perhaps at stroke risk, and a fair number of people did have strokes. And then anyone who has long COVID may be at increased risk for stroke. So all in all, we're going to see more young people with strokes. Now, as any of you who were with me in the Lutheran rehab knew, we couldn't treat everybody on a given day. So what was our sort criteria? Well, the very first one was who's the youngest, right? Because if you give someone a treatment and they're young, you're going to bend the curve, right? If this is how they were going to do throughout their life, you could improve their quality of life by meeting them sooner, younger. So the more you see a young stroke patient, the more you want to treat them as much as you can. And then everyone who's had a stroke or everyone who's at elevated risk for stroke for some reason, whether it's because they have knee arthritis and they can't exercise, or they have hypertension or diabetes or any of those other risk factors, all of those people really need secondary stroke prevention is preventing you having a stroke after preventing you having a second stroke. Primary prevention is if you have elevated risk factors. I will say from a personal note, secondary stroke prevention is particularly important because the brain has a good amount of resilience. to recover from one stroke if it's not too bad. But if you have a mild stroke and you recovered, looks like 100%, but then you get a second stroke, even if the second stroke is mild, still you used up a lot of your reserve capacity rerouting all the wiring around that first stroke. So people are in general much less resilient to their second stroke than to their first stroke. And sometimes it happens that somebody's been having small strokes and we just thought grandpa was getting a little tickety-boo, whatever. But then by the time they have their fourth stroke, even though it's small, the brain's like, that's it. I can't deal. And then all of a sudden they have a lot of symptoms, even though actually the stroke wasn't that big. So does that, I actually want to just take a minute and ask people, is that clear? Does that make sense? Are there any questions to that like risk factor piece? Yeah, is it okay that I'm doing this, Tom? Yeah, good. Okay, any questions at this point, or should I just keep moving? Okay. All right. Okay. So the patient's had an acute stroke. How do we help them recover? Again, I wrote a whole thesis about this. My team and I, we all developed, we kind of studied what have we been doing, what more could we do? I read so much literature. But kind of the net executive summary here is that it's like an onion, only you have to start on the inside, right? Like lots of different things happen to a person when they have a stroke, saying like, I'm so offended by like, what are the stroke rehab points, right? That's like saying, what are the points for a patient who had a car accident? It's like, well, where? Like what got hurt? So you can't just use a point prescription. You need to ask the question, what are we fixing? And so I think of looking at the patient from the inside out. First of all, are they there? I'm like, first find the patient, right? So do they have shun? Is their shun clouded? Is it scattered? Is it agitated? Is it just diminished? So what's their shun doing? Now, we do this all the time. We just do it at very subtle levels. So something I think, you'll be pleasantly surprised by if you do start treating stroke is that all of your skills are way sharp enough because the pathology in stroke is so big that you'll find it's like giant orange arrows saying, needle stomach 36, needle do 20. Like it's not subtle, actually, refreshingly, right? I find clinical practice now actually in some ways more challenging because the stroke like tells you what it needs. So is the Shen present? Is there a problem with vertical hold, right? Are they hyper? Are they somnolent? Pretty often there's a circadian rhythm problem, right? That they're sleeping all day and then wakeful all night. That's like Sharon Weizenbaum's like yang and right relationship thing, right? That's all of our getting people in sync with time. That approach is really helpful. Depression and anxiety are so common in stroke, right? Like so common that literally there's not good agreement of, is it a comorbidity or is it just part of the thing that if you have a stroke, of course, you're going to be depressed, right? Sort of similarly with cancer, and then anxiety for the same reasons. So you know how to treat all this stuff, right? It's not actually special to stroke. With the shun, like you're scrubbing the orifices, so you're PC5 kind of thing, right? Heart 5. Then once you kind of located the patient and got them with you in a therapeutic relationship, even if they can't speak, you can know if they're aware. Once you've got the patient in front of you, then you need to ask immediately about acute issues of housekeeping, right? So if a stroke is more than mild, then it may have affected their bowels, which may be unbelievably constipated or may be incontinent. Urination may be incontinent, or they may have urinary retention, which is a drag because it leads to infections. They very easily aspirate food, but even if they're not allowed to have food, they're going to aspirate their own spit, and they're going to have gurgly fluids in their lungs that are prone to turning into pneumonia. So you need to be on the pneumonia patrol. Like REN 17 is great. REN 17 is such a nice safe point. There are a lot of patients who could have used lung one, but you never know how close to the surface a patient's lungs are when you just meet them for the first time in the hospital. Who knows, maybe they had asthma or emphysema or something, and their lungs are really close to the surface, and I don't want to be the person needling, deep lung one on lots and lots and lots of patients when REN 17 is so nice and safe. They're likely to have phlegm, they're likely to have blood stasis and deficiency. So all of these, you know how to diagnose them, and you actually know how to treat them. And it's fine for you to use lung one in your office. I don't mean like it's that scary of a point. I just mean for public health mass market. So obviously, if someone's got one of these acute housekeeping problems, that's what you need to work on. But then the very next priority is making sure that you understand each other. A fair number of patients can't speak, but they totally know who you are, and they can totally give you a reliable uh-huh or uh-uh. Be careful though, because another fair number of patients, maybe they recognize you, maybe they don't. What they are is very frightened of being out of it and totally emotionally aware with their right brain. But if their left brain has a pretty big stroke, they're going to be like really on top of their social gestures. So you'll feel very connected with them. They'll look you right in the eye, and they have no idea what's going on. And they cannot give you a reliable yes or no. So you need to test it out a little, like, am I your brother? It kind of like you would with a kid, right? You're testing what's true and what's bogus. And then once they're understanding, then of course, you really want to work on helping them speak and helping them to swallow. If somebody's young and doesn't know what to do with their life, they should be an acupuncturist who's cross-trained as a speech language pathologist. There's so much to know. There's all these little muscles in here. There's all these channels going through here, the tongue. It's such a rich area. I have not yet met someone who's cross-trained that way, but I can't wait. Then once the person can understand and speak and nourish themselves, I could go into a whole long thing about what a drag it is to not be able to drink properly. So that's really a high priority if swallowing is an issue. But once you have gotten somewhere with swallowing, then the next thing to work on is balance and trunk stability. Now, everybody is like, I want to walk now, I want to walk soon. You want them to walk too. It's so important to be able to walk, because once you walk, your guts start moving properly, right? That a lot of what happens in stroke is the chi machine, right, which is a clock, got thrown off track, and either it's stuck closed and you're constipated and retaining urine, or it's stuck open and you're losing fluids all over. Walking is a really nice way of restoring normal movement of the chi machine. However, you cannot walk safely if your balance is bad, or if your trunk is not stable. So people with Pons strokes in particular just can't, there's this like boneless look about the trunk. So what do you need? Extra vessels. And then a lot of people who have stroke, their trunk is okay, but their balance is just off. There's even something called pusher syndrome, where they feel like they're falling onto their good side. So they push with their good side onto their bad side. That's a drag, right? Because if you pushed onto your good side with your bad leg, that would be called good training, but it's the opposite, and the bad leg buckles and they fall. So someone like that, you need to work on that stuff. Extra vessels for the trunk stability. For balance, I like bilateral, like 0. There's a point called posterior hypothalamus in the Terry Olson auricular book. All of this stuff is in my thesis, which is free online. I give you the link later, so it's not urgent to write it down. And then after the trunk is stable, then it's a good time to learn to walk. And pretty often people are like, my arm, my poor arm, because very often the arm is just like not moving at all, whereas the leg has some movement, it's just weak. They really should work on walking before bothering about the arm, because if you had to choose, you would much rather be ambulatory with a bad arm than wheelchair bound with a good arm, right? Because it's not going to be a great arm. In general, most of the strokes are middle cerebral artery strokes, and in general, for those strokes, the leg comes back better anyway. So you might as well play to your strengths and work on the arm first. So that was a mouthful. That often this paragraph is a whole weekend. But I think you get the idea. And again, what's important for you to understand is you do have the tools, right? They might not be like the best, most up to the moment tools, but they're totally adequate tools with whatever TCM or Japanese or Korean acupuncture, So there's always an idea of what constitution caused the stroke, right? Sometimes there's obvious, like phlegm, heat, yang rising with blood and yin deficiency, and heat is a common one. There's also the yucky phlegm damp, kind of Jabba the Hutt stroke. But all of them, underlying all of those, is a general pathology after the stroke happened, whatever constitutional reason caused the stroke. After a stroke, the channels are empty of qi and the luo are full of stuck blood. So what do you do to move stuck blood? Do you bleed? Great, bleed. What do you do to refill empty channels? Do you moxa? Do you tuina? Do you massage? Do you, have a really good hand technique so you are quite confident that you're really putting qi in? Great, then do all of that. Whatever you do to fill channels and to move low. Guasha is great. I'm a huge fan of tuina for stroke patients, and acupuncture, teaching the family acupuncture, teaching the family tuina, foot soaks in ginger or whatever blood moving soak you want to give them as often as possible. Sooner is always better, but there is no time limit on any of these treatment goals, right? Like, so just like someone can have migraines and it's Guggen tongue pattern from a cold they caught when they were 12, you can unwind a stroke pattern. So people will come like 10 years after their stroke and they're still constipated, and you move their constipation and a whole lot of other things get better. So this is kind of the big picture of the phased approach that I developed for my PhD. I'm sure, it's not like I'm the first person to ever think of that. Obviously, there are lots of great practitioners in China who've been doing a lot of work on stroke, and they, I'm sure, do this kind of thing, but I haven't seen a resource like that for meeting the patient where they are with what their developmental needs are at the moment. And I think that's really important. I think it's something we should think of for other conditions. It's a coincidence, I think, but birth is a little bit that way too, right? It's like, what do you need now? What do you need at this point? What do you need at that point? So the PhD is a free download. The URL is in the resource section. Oh, I just thought for fun, I'd show you a before and after tongue. If you look at that tongue on the right, you wouldn't normally say, look how much good we did for this patient. But actually, if you compare it to the tongue on the left, that's a way less unhealthy tongue, right? So when I say it's not subtle, I swear to you, I really, really, really mean it's not subtle, right? You can see that there's cold and deficiency and stagnation, but still yet there's yang rising, that nothing is moving in the middle and lower burner, and that it's moving more. It's less, significantly less deficient and stagnant here. That there's definitely still a ways to go, but this patient is way better off than they were 2 weeks. And indeed, this patient at the time this first picture was taken, he couldn't turn over in bed without 2 people helping him to do it. And when I did the qualitative research for my stroke study, the nurse for this patient said, you know, it was the most amazing thing. He was a 2-person assist, but then a few days after the acupuncturist came, he started being able to turn over with much less assistance, right? And it's not kind of big on the list of things you do for stroke, but just helping them be more mobile, less helpless. And as you can see, his yang is in much better shape in the second picture, so it makes sense. So I just thought I'd share with you a couple of, you could call them oversimplifications, for getting the big picture of how our basic TCM tools can help someone with a stroke. So this picture should look a little familiar to you. I laughed when I first saw it, because this anterior cerebral artery in yellow here, that's the bladder channel, right? It goes right from the forehead here up to like D19-ish. And then the middle cerebral artery at its superficial part of the brain, it's totally Shaoyang territory, right? And then deep in the middle cerebral artery, if you see pictures of it, it has a branch that goes deep inside and has these little branches that go up, and those are the ones that are most prone to getting messed up when people smoke. And the strokes from those are really damaging because they're so deep, they take out a whole swath. Anyway, so that's gallbladder / liver, is the middle cerebral artery, and then the posterior cerebral artery and the other kind of posterior and inferior vessels, those are deep, right? So that's like Du and Rin, kidney, bladder, and liver again. We'll show, yeah, from like, you can think of it as being like, if you're old like me, you think of it as being upstairs, downstairs. And if you're only slightly old, then you think of it as being Downton Abbey. It's like, you know, the nobility live up here and the servants live back here. So in front of Du20, you have like right in the front, you have the self-awareness, like the awareness of awareness. That's like yang within yang, executive function. What should I think about thinking about doing? And then the frontal lobe is just straight up yang, right? It's concentration, decision-making. And then the motor cortex is like, I want to do this, so I'm going to do it. So that's in front of Du20, right? So that's motor line. And then what's right behind motor line? Sensory line. So sensory is like the most yang of the yin things you can do, right? You can notice what's going on. You hear, I don't have to do anything, you know, there are certain things I'd like to unhear, certain things I'd like to unsee, but I can't. It's conscious, it's non-voluntary. So the different kinds of speech, right? Broca's aphasia, when you have Broca's, the Broca area is injured, then you know exactly what you want to say, but you can't make exactly the words you want come out. It's slow and it's effortful. Does somebody need to unmute, I think, or need to mute? And then Wernicke's area is further back here, and that's hearing and understanding what people are saying, and kind of hearing and understanding what you want to say. So people who have Wernicke's aphasia, they're like, blabbity, blabbity, my speech is perfectly fluent, it's tumbling right out, but I have no idea what I'm saying. You know, it's not at all grammatical. And there's a kind of a sense in it. One of our stroke patients in the study was saying, like, it's the funny it's hard to mimic. I'm not that good of a like whatever actress, but she's like, my up thing and down, I don't know why the up down isn't upping and the thing is the not and she was actually kind of, her spirit was all scattered and her poop wasn't coming. There were lots of up and down that were problematic, but she just wasn't bringing any of it out. So that's behind do 20. And then in the back, the cerebellum stores like things like, you know, putting the key in the lock, opening a doorknob, covering our mouth when we sneeze, unconscious movements that we don't have to think about to know that we're doing. We look up and we're doing them. Then, and also a lot of balance, body function, reflex, all that stuff lives in the cerebellum. And then the pons, the medulla, and the brainstem are all like downstairs. I think I have a picture. Yeah. So this is like, you know, upstairs in front, right? Executive function, prefrontal, frontal. Here's motor, here's sensory. And then we're going back and back and back, cerebellum. And then here's all the like servants' quarters down here, where this is just, oh, don't mind me. I'm just keeping you breathing and keeping your heart beating and digesting your food for you. But no, it's okay. I don't need minimum wage or anything. You know, it's like, we don't give enough cred to these guys down in here. And it's kind of a design flaw, right? If I get a hemorrhagic stroke and my brain fills with blood, this is leading down to the spinal cord. Here's the foramen magnum, the big hole in the skull, and just the pressure in the brain starts to squish the most important part of our brain from a survival perspective, just gets squished into the foramen magnum. And you can die just because you stop breathing because your cranial pressure is too high. Whereas if someone could just cut a flap off of your skull, trepanning, they call it, and relieve the pressure, you'd be fine. I mean, not fine, but you wouldn't die. So that was a super fast talk through what goes where. And my goal in doing it was that to help you understand if your patient has an anterior cerebral artery lesion, where that's going to be, where the damage is going to be, or even better, if you can see, ask them to bring a radiology report, because you know what, we have channels and the channels go there. And you can for sure, of course, treat the scalp, and we do, but you can also treat distal points on those channels. So, you know, GB40 and 41 for this region here, liver 1 and liver 3 for these deep strokes inside here. You know, small intestine and bladder points for these guys, and kidney, and I really like Ren and Chong points for in here, right? So you can really let the let the physiology relate to our medicine and really do understand that the patient who has a stroke here has an injury to their yang, and the patient who has a stroke here has an injury to their yin, and here to their jing, right? Like it is that like simple-mindedly straightforward at the big picture level. Of course, you can get more sophisticated, but do not feel disempowered. You do actually know enough. Use your extra vessels, right? Du and Ren, yin and yang chow are really important for the legs getting going again. And trunk stability, of course, Dai for trunk stability, right? I didn't write it in there, but it's important. Distal points by the location of the lesion. And also, you know, like Jing Wells for whatever you're trying to change. Local adjacent distal is really good for the empty channels and the stuck luo. And then just use the TCM functions of your points, right? GB40, stomach 36. I guess this is one exception. Stomach 36 is an amazing point. It's really important for opening up the leg. Stomach 31, stomach 36, stomach 41 is kind of the large intestine 15, 11, and 4 of the leg. As it happens, stomach 36 is just as good for severe constipation as stomach 37 is, and it's a much stronger, much better point anyway. So I tend to use it by preference to stomach 37. So that's a perfect example of stomach 37 works just fine, but as a little, you know, hot tip for stroke, stomach 36 works even better. I really like the balance method, the Richard Tan, you know, balance method. So yang points, yin points, yang points, yin points, to kind of pinwheel the chi. Right, to make it move. So it's not just the functions of the points you choose, it's the locations, the big picture locations. I use 2 systems of scalp acupuncture, the Jiao system, which is the one we mostly learned in school, which is just the biomedical brain regions. So basically any brain region you can find here, you can needle right over it with acupuncture needles. I'll even run e-stim. What I don't do is those big, long 3-inch needles that we thread. What I instead do is follow one by one, right? I'll just do maybe 4 ear needles to cover an area. Or I'll do a needle, say, at the top and the bottom of the area for the hand, and then I'll run e-stim between these 2. I will not run e-stim across where it might enter the brain. I'll just needle it over the surface of the scalp. So that's biomedical. And so you do it on the side where the lesion is. Now, the Ju system and the Yamamoto scalp acupuncture system, they're microsystems. So they're actually Chinese medicine, some more ipsilateral than contralateral to the problem. But the Yamamoto has its own system. I saw a demo, I was at the PCOM symposium, and I saw a really cool demo of Yamamoto stuff by David Bomzon. So I'm intrigued by his work. And then we talked about the Tuina, the Guasha, the Dao Yin leading the patient's qi, right? So as you're needling their foot area, you're massaging the foot, asking them to imagine moving the foot, asking them to imagine breathing into the foot, and all of that. And again, you can just bring your own technique. It's not that there's one magic technique. And all the soaks we know, you know, the Zhenggu Tuina soaks that Tom sells are very good for as long as you know your functions for moving blood and like that. They're perfectly good to use. So that's kind of our basic toolbox of approaches, again, from kind of a big picture perspective. So that was kind of part 2, was a quickie overview of taking care of stroke patients. Are there any questions at this point? Does anyone have anything they want to clarify or whatever? Or I'm going to go on to the thing that I'm stoked to talk about that's a little newer for me, which is doing this. Oh, there's a raised hand. Excellent. I'll stop sharing for 1 sec. Diane, yep.
Yes, just I missed, who did you say does the balance method?
I'll write it in. Oh, the balance method is what's his name? He's passed away now, Richard Tan.
Oh, Richard.
There you go.
Thank you. Thank you. Thank you.
Yep. Mona. Hi, Mona.
Hi, so nice to see you. Thank you so much. I was wondering about memory, where like short term in the brain, I realized I don't really know like where, and yeah.
Yeah, well, so the hippocampus is really central. Basically, like memory is really poorly understood. So short-term experiences happen. We think emotion is a little bit of a mnemonic device to record the memory. So there's no one location. Oh, that took out my memory. And by and large, stroke patients don't lose their memories, but if the hippocampus is damaged, they lose the mechanism that writes memory from short-term into long-term. So that's where, so the hippocampus is, so what's the name of Terry Olson's auriculotherapy book? I think it's Auriculotherapy Manual. I love that book because it provides us a way to talk to the deep brain structures, right? Because scalp acupuncture just addresses the surface of your brain. Yes, that's it, Janine. Thank you. Yeah, how would you, if I wanted to talk to the thalamus, what on the scalp would I needle to talk to the thalamus? That's all the way in the middle there. But if you go inside the ear, now you have like external, internal, deeper. So you can actually, all of these little basal ganglia are all around the, my language is terrible. It's all in here, but it's one of the microsystems that Olson shows, and it's the bomb. It's the brain, the deep brain structures projected onto the ear.
Thank you.
And so use that for all kinds of things, right? Don't just use it for stroke. It's super helpful. I have Parkinson too, as it happens, early onset Parkinson's patients. And so I'm always doing their like substantia nigra points and their reticular activating system points. Yeah. Any other questions before we go into the idea of consultations? Excellent. All righty.
I had one other quick question.
Yep.
Are there any contraindications for like hemorrhagic versus ischemic?
Yeah, so you don't, any stroke you want to leave alone for 2 days, which is easy enough to do because they're in the hospital. They don't want you there anyway. And then hemorrhagic stroke, very often there's going to be a big fat, surgical scar here. So you're just going to not go anywhere near it anyway. But by and large, with an ischemic stroke, you want to be very even technique, raising the clear yang, descending the turbid. But you do want to start that as soon as possible. And then with hemorrhagic stroke, you don't need to worry that you're gonna, needle the wrong point and their head will explode. It's not like that. They're not walking on a hair trigger, whatever it is that gave them the hemorrhagic stroke. The doctors are fixing it already. You're gonna not raise a ton of chi really strongly in a hemorrhagic stroke patient, but it's much more like the kind of caution you'd have for a weak patient. than it is an urgent, don't you dare, it's, but yeah, use good sense and be conservative for the first 3 weeks, but I'll do 20 and 24 PC6 spleen 6, do 20 and 24 LI4 stomach 36, conservative balanced treatments that both go up and go down. Something that's really important is that treating a patient who's had a stroke is like nourishing a patient who's had vomiting and diarrhea, or talking to a patient who is cognitively impaired, right? You can't say this whole oh, I'm going to do a very fancy treatment with lots of the few and a dab of this and a smidgen of that. And, that body is not going to understand what you're saying to it. You need to communicate clearly, say some chi up, some chi down. That's the level of communication you want. I'll typically use 8, 9 needles for a post-stroke treatment, not too many until they're much further down the road. All right, anything else? All right, let me reshare and we'll do this last section. So this is a little bit of a work in progress, but I'm really stoked about it. And that is this idea of using our kind of Shaoyang, half in, half out of the medical profession status to help people manage their risk of this terrifying disease from a cross-cultural perspective. So you're going to use both our East Asian medical exam, right? And what is their constitution cruising for bruising with? Do they have a lot of phlegm? Do they have a lot of blood stasis? Do they, I didn't do a whole stroke etiology in this talk, but you kind of know them. And if you don't, they're in chapter 2 of the thesis. You get a photo of their tongue. I love getting tongue photos these days because it lets the patient track their own progress, and you can look at it for as long as you want. And then if you want to also look at their tongue live, that's great, but it's really good to have the sort of documentary evidence. So I strongly encourage taking tongue photos. And then your basic age, your basic biomedical risk assessment, right? Basically the interstroke, those 10 items, particularly activity level. And a lot of what you're going to do is so many patients have a fundamental injury to their willpower, right? Either they're addicted to something, or they don't exercise enough, or they eat poorly. And they just blew through their ability to make themselves do stuff they don't want to do. And you can, help it's a tiny little bird that you're feeding with a little dropper, well, so do you have time to do 2 minutes of Qigong before you go to sleep, right? You're literally helping them to find self-care interesting and novel enough and well enough supported by their relationship with you that they're going to do it. So you start with that idea that you're going to basically help them to do the same, eating better and exercising more that we all know everybody should do, but we're right sizing it to them and understanding. So for example, people with liver qi stagnation very often can't discipline themselves, even if it's 2 minutes, they can't do it. So if that's the problem, find something they want to do, I don't know, go to the gym, whatever, something that is rewarding for them that they will do. And if none of it is rewarding, then do something well, you can have a Starbucks if you go walk for it, stuff like that. Digest the information, right? Stagnant blood and fluids, severe deficiency. These are our East Asian medicine risk factors. And then how many biomedical risk factors? You know, people who have no major stroke risk factors, they're young, but they do have high cholesterol, they shouldn't really be on Lipitor. You know, it's not on us to take them off it, but you should really ask the question and send them back to their doctor with the question, how many risk factors do I have? Because that's exactly the kind of patient who should try to lower their cholesterol by exercise and eating a little better. So provide a worksheet. I have a worksheet. I'll pop it up in one sec. Start with what's easy. That's the most important thing, is to find ways to use this as a way to structure the same old discussion about yang sheng and nourishing vitality that you were going to have with the patients anyway. Use this as a way to structure it around their concern about not having a stroke. So you kind of, for every patient, you want something that's nice and easy that they're totally going to succeed at and feel good about. And then you want to choose something that's really important, like quitting smoking. You know, someone comes to you to quit smoking. You don't say, okay, let's do it next week. You kind of make a schedule, you make a timeline, you make small changes at first, you know, smoke fewer, wait 45 minutes after eating, you know, do that whole thing of building good habits by stringing them along with other good habits, right? So that's why we have our patients put their T-pills next to their toothbrush. So, you know, most patients can brush their teeth twice a day. You know, that's usually not a stretch for most patients. So to string something onto that is pretty easy. And then conversely, when you want to break a bad habit, you put friction in. So you say, okay, you can totally have dessert. The thing is, you have to wait an hour after dinner before you have it. And usually by an hour after dinner, the urge is past. Not always, but sometimes. And anyway, the urge is less. So the easy changes make right away and practice success. And then the big changes, make a timeline, make a plan. And for every patient, have an easy one, a big, you know, dream big, and then probably something in the middle. So that's doing, I think I'm actually gonna share the worksheet right now. Here it is. So this is what I use. So on the left are all the risk factors. So you can just go down one by one, and you can kind of make it a conversation with them, so that we're in this function of like helping them understand their Western medical diagnosis if they need that, and helping them understand our perspective, like why we think insomnia is so important, sleep deprivation, whatever. And then here are our patterns of disharmony, the ones that are really important to stroke. And then here, I use this, and I actually use it more and more. And again, it became really convenient doing the first, instead of having a long new patient slot that screws up the rest of my schedule, I just do a separate online consult. And I think you guys may also notice as there's something kind of intimate about Zoom, right? You're right here with someone and they're in their own home. And so you can sort of see their home a little, and they're just a little more open and available in my experience. I feel like I get to know them a little better if I do my initial intake separate from the acupuncture, and it gives me a little more time to think too. I'm kind of a slow thinker. So if it's a tough case, I appreciate having a minute to research it before coming up with a treatment plan. So we can have this conversation about like, okay, here are approaches I could take, right? I could do gua sha every 2 weeks. How do you feel about gua sha? Is your, partner going to flip out? Do you hate it? Is it winter? In which case we're not going to do it right now. We'll wait till summer or whatever. Moxa, can you do moxa at home? Will you take herbs? So you just write down all the things you might do, and then you circle the things you're going to do. And then teach them some exercises, have them do other lifestyle stuff. I'm a big fan of like, get people out first couple of days, first couple hours of the day. Just I'll say something like, make sure you poke your nose out in the sunshine. No blue screens after dinner is a good one. Stuff like that. So I hope that's helpful. Let me get back to this, and this is kind of the tail end. We're just finishing it up. So I also think that these kinds of consultations stick better if there's a community. In particular, lifestyle medicine, I think we really underuse it. And I think just like dry needling and what do they call that? Graston technique, where the PTs are trying to appropriate gua sha. We should better occupy our lifestyle medicine, or I promise you, life coaches will come and take it. There will be, Taoist life coaches who will not need to go to acupuncture school if we don't really hold our expertise in this. And so I actually started a group both at my clinic, where, one of the other practitioners at, we both work at Sharon Weisenbaum's clinic, one of the other practitioners there, and I lead a thing every month where people come and do the seasonal alignment from Tom Bizzio's book, 8 Winds in the Heavens. So that's there's winter qigong and summer qigong. There are food recipes and teas and just kind of Taoist advice about when to get up and when to go to sleep, and how to understand the movement of yang. So for example, right now we're in the time when we should be holding on to our yang, hiding and subsiding, but within that the yang is really starting to get strong. We're in a new solar mode as of yesterday. And the yang we should be nourishing our yang, but not expressing it. So not partying, not drinking too much coffee, just nourishing our yang and keeping it quiet. Looks like there's a question in the chat. Yeah, okay. All right. So, both for us doing the consultations and also for the patients trying to do lifestyle medicine, if you have patients working on similar issues, have a Zoom meeting for everyone who's working on stroke prevention, heart attack prevention, whatever, monthly, just the way that Tom has rightly gauged that our little band of acupuncturists benefits from having this kind of a visit. Consider yourself hosting one for patients, especially if they're a little lonely. They love having somewhere to go and connect with other patients. And even if they never come to the meeting nor even watch the video, just getting the email will remind them that they're not the loneliest, saddest, unluckiest person in the whole world who has to deal with this problem, right? It's just, people really benefit so much from being reminded that they're not alone, they're in a group. Zoom study groups for people like us, and also for your patients, right? Basic concepts, nutrition concepts. You could, I like it's not my favorite book, but I like the Cosmo quiz that Between Heaven and Earth has, where people are oh, am I the magician or am I the, whatever. Again, I'm really enjoying this 8 Winds in the Heavens book right now. I'm doing the spinal alignment, qigong, all this philosophy, lifestyle stuff, the teas. I just think it's a blast. And he also has a video course, so you could have people purchase the video course and go through it together. Here are my resources. Here's, I promised you, a free link to my PhD thesis, or you can just Google Citkovitz stroke. That's the one upside of having a weirdo last name. Jason Howe's scalp acupuncture book is a great description of the Jiao system. Ming-Ching Ju's website, they sell needles that are a little better for inserting in the scalp. They have, atlases of his stuff. They have courses in his approach, although I think they're not up and running again since the pandemic. I believe he passed away, but it's his whatever protege who's teaching it. And then I've been really impressed with this David Bomzon guy. He's in Israel, but he teaches all over the world. There's a training coming up in Lisbon, and I'm like, ooh, Lisbon, I love Lisbon. And then I forgot to put it on, I think. I did. The most important thing. I'm doing a 6-month training. It's like at your own pace. Every month there's going to be 3 hours each of Western background and Eastern background, and then some like material retention questions, some studies and stuff to read. And then we'll have like a case discussion. Either I'll present cases, or you guys, if you have cases, will present cases. It's sort of the approach that I took with Deborah Betts in our pregnancy mentorship, but it's much cheaper than that because most of the material is recorded. And so it's like prevention, so three hours each of Western and Eastern. Whoops. That means our intent is up, but we're right on time. So the modules are going to be like prevention, what to do, like if your Nana gets a stroke, how can you help when what's happening, what are they looking for in the ICU, what are they testing, how can you help, early recovery and rehab, late recovery and rehab, getting them home, outpatient care for relatively recent strokes, and then outpatient care for more chronic strokes. I think that adds up to 6. Anyway, those are the basic modules. If people are interested in that. And then I just I did a bunch of reading when I pulled together this talk and another one I did recently. So I just thought I'd share them all with you. If you want the live version of this that has, these links are live, so you don't have to copy them by hand, just email me and I'll send you the original of the thing. My email is studyingpractice@gmail.com. I will put that in the chat in 1 sec. Whoops. All right. You can see I cribbed it from another talk. Sorry about that. So practice@gmail.com. Yeah. So back over to you, Tom.
All right. Thank you so much. That was very enlightening, at least for me, Anyway, so on behalf of the group, Claudia, thank you for being so generous with your time and your knowledge. And we appreciate, and I can speak behalf of many acupuncturists and colleagues, that we appreciate the good work that you do in the profession. And keep it up. All right. So anyway, we're going to move on to next would be the Q&A session. So if you have questions for Claudia, if you can just please raise your hand and we'll call on you. Okay. So anyone?
All right. So if no one has, thanks.
Oh, okay. We have one. Okay. We just unmute yourself.
Hi, Claudia. I'm just wondering, how often are you treating? I remember in school people saying, oh, you have to treat 2 or 3 times a week. You have to treat very often. Does it matter if it's acute or longer? Obviously, if it's later from when they've had the stroke, it's going to be different. But what's your approach?
So it is true that more is better by a lot. But you don't have to go back to the drawing board for every treatment. Right. So they could come in, figuring out how to fit a stroke patient into your practice usually involves time management, You know, do you treat them in their wheelchair if they're in a wheelchair? Do you have an afternoon lull and they can come at that time because they don't have to fit it in with work? And then once you've set your treatment plan, you can actually just do variations on it without doing a deep reevaluation unless they report big change, right? So it's not like someone with, I don't know, you know, menstrual stuff where you have to find out where they are in their cycle, and but you don't have to do a deep discussion. But yeah, twice a week is much better than once a week. 3 times a week is even better, but that's a little, you know, aspirational. But yeah, twice a week is definitely much better. So if you have an assistant, if you can teach the family Tuina, if you can teach them movement, but yeah, it's hard to get serious forward progress with just 1 time a week.
Okay. Thanks.
Sure.
Okay.
I should say, the younger they are and the closer they are to having had the stroke, the more once a week is adequate. And it's better to treat them once a week than to not treat them at all.
Okay.
Yeah.
Thank you for that question. Anybody
Sure.
else? Anyone else have questions? Oh, okay. We have Diane. Diane, if you can unmute yourself.
Treat 1 to 2 times a week or even 3 times a week, even if it's been like several years after the stroke.
Absolutely.
Okay.
Yeah.
Wonderful.
Like so basically, for helping their body recover from the stroke, urinary retention, constipation, there are lots of things, depression, sleep, there are lots of functions of the chi machine that are going to be messed up by the stroke that just doing good Chinese medicine will help with, or sa'am, or whatever you do will help with. And then in terms of motor function, basically, if there's a 3-part severity, like if they never really lost function, it just doesn't move very well, then they can recover fully if only they work hard enough on it, by and large. But you can help them recover better faster. If the area that runs, typically it's the arm, right? And the middle cerebral artery stroke is here. So if it's really just blasted out here, it's like hardware and software, right? If they just need a software reboot and you can find that there's, you know, part of the disk still works and the part of the information is somewhere, then they can get it back again. But if it's absolutely, there's no hard disk there, there's nothing to restart, then the arm's going to look like this. And it doesn't do any harm to try. I have a whole thing I try with very strong electroacupuncture. And if they get like a little waggle of the finger, that's enough to tell me that there's a little filament through that's enough of a connection that maybe they could redo it. They all come in with so much hope. So you don't want to say no, but what you do want to say is, let's try it 3 times. And if we don't get anything back by the 3rd time, then I think we probably should work on other things. And in the meantime, you're working on other things and they just realize how much better they feel because their blood stasis is better. You know what I mean? So can you help people with blood stasis by treating them once a week? Absolutely. You do it all the time. They have blood stasis and empty channels, and they're going to feel better if you treat them. They're going to make the most forward progress if you treat them twice. But basically, mild damage to the brain, they're going to get better anyway, but we can help it be faster. Severe damage to a particular area, you're not going to get that motor function back, but you can help their body feel better. And then in the middle, that's the group that we help the most, because they probably won't do too well without us, but we can help them to join the mild people. So that's, I'm sorry, it's said better in other places, but that's kind of a oversimplification, but there you go.
Okay, great. Thank you. And Margaret has a question. Margaret, can you unmute yourself?
Hi, I had worked maybe 15 years ago as an RN with a lot of stroke patients. And I'm wondering if you can speak to us or advise on the psychosocial dynamics of the family and the patients, how to be supportive, or what other team members can be really helpful for getting support for our patients.
Oh my God, that's such a huge topic. I'm not totally sure. I'm like both. Oh, I'm totally with you. I want that too. And I'm not sure exactly what piece. How can acupuncturists help the family? How can who's helping who to do what?
Yeah, so I guess for the folks who are doing the best that come to your office, what kind of situations are they in as far as getting support, or being open to having caregiver support from you or from others on the team, so that then indirectly or directly helps the patient that you're treating?
So the more the better. Right. I mean, I imagine that's your experience too, right? I'd like, which patients are doing best in my practice? The ones who have the money to spend on, you know, still going to physical therapy, still going to OT,
Okay.
still having caregivers. Like the more resources, the better.
Yeah.
And that's just life's unfair. So I try to make it a mission to at least educate the families as to how to do Tuena and how to do, you know, movements that are, you know, they don't have to be official PT. So for example, and I know we're at time, Tom, so I'll try and be mindful. Constipation, right? So many stroke patients are constipated. So I have them, you know, take the affected hand, hold it in the good hand, and teach the bad hand. You know, it's like they're both doing the belly rubbing that they need, and they're also giving their affected hand a job that it can do, right, in partnership with their good hand. And it provides so much tactile stimulation, and it's like occupational therapy for the hand because now it has a job, something like that. So I'm always trying to use our yin-yang Chinese medicine lens to give the caregivers of the family a feeling that they have things they can do that really help, which is another point of similarity with birth, right? Like they're full of love, and if only they had a vector they could really give it to their family member, they would. And lucky us, we get to give it to them, something like that. Yeah.
Thank you.
All right, great. Thank you. Anybody else have a question? If not, I'm going to ask mine. Okay. All right. So I will ask mine. Claudia, so this is my question, and this may be, I apologize ahead if it's a stupid question, but for stroke patients, how aggressive is the needling? Does it, you know, when does it need to be more aggressive than your ordinary patients? Maybe you can talk a little bit about that.
Question. Yeah. You need to right size it to the patient, right? Some blood deficient patients are off the charts, more needle sensitive. In general, the worse the stroke was, the less needle sensitive they will be. And so you can go to town on the needles, especially on the affected side. If it's the left side that's affected, you can wail on that sucker, because they have something called neglect, where they're not even really noticing what's going on there. And so when the patient starts whining to you about your needle stimulation is too strong, that's great. You're delighted that they start complaining more, because it means that their feedback mechanism is working better. I used to be all about needling right into the joint space, the deep fascia to go in here. And then a colleague was like, you could just do 2 needles, one at the yin spring and one angled into the hand this way. And actually you get more rubber on the road and it's less hardcore and painful, right? So I came from Tom Bizio's shop, right? So I originally, when he was a young guy, it was all, 28 and 30 gauge needles and strong stimulation, but now he just taps them in and it's the chi that does the work. So you can be aggressive. It's often useful to be aggressive when they have a lot of phlegm. Phlegmy patients are so non-needle sensitive. And sometimes it can be good to be gentler.
Great, thank you.
Sure.
All right, and with that, we will end tonight's session. And thank you again, Claudia, and thank everyone for attending tonight. And please make sure to check your inbox or your spam folder for your coupon. Okay, so everyone, good night.
Thank you, guys. Great to see you all.
Okay, bye-bye.